I bring you greetings from Sri Lanka, and thank you very much, Dr. Duru, and all the organizers for inviting me to this very meaningful meeting. May I, with your permission, change the title from South Asian versus White European rather than Caucasian, because it was one of my very early teachers in physiology who pointed out that Caucasians do also include us Asians and many other races. So let me try and take you through, after that excellent introduction by Helena, on the phenotype and some aspects of the genotype of women from South Asia. As you could see, there is no unique phenotype, and the polycystic ovary, particularly with no disrespect to the gynecologist, often tends to be the prime mover in the entire management of such women. It has also been can be even overlooked, while the Rotterdam criteria very clearly showed that polycystic ovary, not all women with the ovary would have the symptoms, at least in the early phase of their lives. So with no disrespect to the fashion page Miss Sri Lanka, I would like to name my patient Miss Sri Lanka, who's 28 years and is due to marry in 6 months, who comes to me with a complaint that her cycles have been irregular from the age of 16, when she attained menarche at 13, and our local data shows that generally the initial irregularity corrects itself in normal girls in the community around 1.5 years after menarche. So she has less than 6 periods per year. She has had 8 months of no periods, followed by heavy prolonged bleeding, which has been treated by her GP with some tablets for over 4 weeks. She has gained 25 kilos over the previous 7 years, and her current BMI is 32. I would like to know from the audience how, with this picture, how you would like to put this in one sentence as to what her key problems are. Any takers? Yes, madam?
You know, what I would really focus on is the BMI of 32 kg per meter square in this patient, which probably has, kind of given a push to her genetic risk of getting PCOS. Okay. And this is the final environmental push, because of which she has now gained weight and now had ovulatory cycles, which have finally led to amenorrhea.
Thank you. So she no doubt has oligoamenorrhea and probably dysfunctional uterine bleeding, with, particularly as you said, made worse by the weight gain. She also complains of hirsutism, which is very relevant to the fact that she has to face a wedding in 6 months. Thick, curly, dark hair growth on her chin, upper lip, upper and lower abdomen, thighs, and some facial acne, and some loss of head hair, which is more frontal. She also complains of dark skin with tags on her nape, dark patches on her armpits, between her breasts, knuckles, face, and also nasolabial folds. And therefore, we have to put this together as being hyperandrogenism and acanthosis, in addition to what we spoke about of her periods and her weight problem. If we were to deal with the hyperandrogenism, as Helena said, I think it would be important to us all clinicians that we need to quantify the degree of hirsutism, at least for baseline data and for follow-up, and well knowing that there are ethnic variations based on the fact that there is hair follicle sensitivity to the final active component, the 5-hydroxytestosterone. In terms of alopecia, it could be even iron deficiency, which is so common in our part of the world, so we should keep that in mind. Acne is probably more in adolescence, and it correlates fairly poorly with hyperandrogenism. So Rosenfield many years ago said that about 5% of women in general populations are hirsute, and this is indicated by a score of 8, which is going to be modified, as Helena suggested, and about a half of them are probably truly hyperandrogenic. So the FG score, which varies by ethnicity, should be kept in mind as we go along in our discussion. So I'll take you back to some of our own data of a fair number of women the baseline data of treatment-naive groups of women who came to our clinic, and acanthosis was quite common. As you can see, the neck, antecubital and nasolabial folds as well, which we were not very sure, but we reported it and it was published in Human Reproduction. While a family history of diabetes was also quite common in this group of young women in their 20s. But you can see from this picture, so they are hyperandrogenic, they have acanthosis and probably insulin resistant, and the hyperandrogenism particularly has adequate breast development as evidenced by the adequate, therefore we could say there is enough estrogen circulating in their bodies, as opposed to the hyperandrogenism where they have low estrogens, which are a different group of problems which we need to exclude. So going back to simple aspects of history, these are what I would like to highlight, which we really need to address, even though it may be in a different setting of infertility, as to what their previous medical history is, particularly whether they take steroids, whether they have had galactorrhea, whether their facial features and ring and shoe sizes have changed, whether they are on antidepressants, whether they have been treated with metformin, and whether they have a family history of diabetes and other premature cardiovascular disease, and whether there was parental consanguinity. I would like to highlight that the reasons why I want to ask these features is to exclude the secondary causes entirely by history itself at the beginning, the exogenous Cushing's, prolactin excess, acromegaly, metabolic syndrome being caused by antidepressants or made worse by antidepressants, then prescribing practices of metformin, and also the family history, particularly in view of non-classical CAH. So on examination, she has no clitoromegaly, which probably means that she has non-virilized hyperandrogenism. She's not Cushingoid, she has thick skin and no proximal myopathy, but her blood pressure tends to be in the pre-hypertensive group. She has no thyroid enlargement, so therefore we think she's clinically euthyroid. Acanthosis is striking, as I showed you. She's hirsute. She has some acne and normal breast examination. As well as there are no features of visual problems which suggest pituitary tumors. So what would you do next is my suggestion, request from you, and obviously it would be investigations. So here again, very often I find, at least in our local setting, that many a woman have had a scan for these symptoms and been started on treatment without baseline endocrine workup, which is absolutely important because you can miss that occasional variant which is not PCOS. So timing of the gonadotrophin assessment is extremely important, ideally within the first 5 to 7 days of her last period, or else if she has not had a period and you are sure she's not pregnant, that you can time it at any time, but preferably in the morning because the sex steroids come out best at that time. The thyroid functions have been normal in her as much as a prolactin, and as Dr. Duru said, testosterone is in the upper, just above the upper range, but not coming up to very high levels, and therefore we practice because 17-hydroxyprogesterone test in the government sector is very expensive, and we generally try to select the women in our routine practice if they have features, then to go on to an ACTH stimulated 17-OHP to exclude NCCH. But the overnight dexamethasone suppression test is what we would do in routine practice to exclude Cushing's if we have any suggestion of it. And we would, as Helena suggested, do the 75-gram oral glucose tolerance test, particularly in this premarital woman who is likely to start a family. And what did we find? The 2-hour value in milligrams per deciliter fell into an abnormal range. Her lipids, total cholesterol, triglycerides, are also high, as much as her HDL being low, and her liver enzymes is another one test that we would do as physicians, are also high at baseline. No doubt the scans have been done, and this lady has WHO type 2 eugonadotrophic hyperandrogenism with polycystic ovaries, and she definitely has the metabolic syndrome with impaired glucose tolerance and fatty liver, non-alcoholic fatty liver disease. So looking at the age group that we generally come across in an endocrine focus, they are often premarital, and their main complaint is hirsutism and to a degree oligomenorrhea. While if we look at the subphenotypes, the well-characterized one is what the majority would have in clinic attendees, while those without hirsutism, which is in pale blue, actually probably occur in less than a third. And in our community-based study where there was no selection bias or it was minimal, carried about 10 years ago, we found a community prevalence of 6.3, where the majority again had oligomenorrhea and of course the polycystic ovary, because we carried the ovarian ultrasound in the field, while hirsutism affected approximately 53%. While the metabolic syndrome fitted in to the diagnosis in 32%, while the majority had a culture of silence, not the majority but almost half, and only about half of them were yet married. So in our part of the world, very often their health-seeking behavior is often from a family member or the field workers. So that is the importance of getting all the health professionals on board to become conscious of what exactly to follow at the suspicion of this diagnosis. So now, no doubt, as was discussed, it is closely linked to insulin resistance and overlapping with the metabolic syndrome features of central obesity, hypertension, hyperlipidemia, and insulin resistance going on to abnormal glucose tolerance. So at the time that I did my thesis on this, on the Asian women with PCOS, what was very apparent was that in our part of the world, the prevalence of impaired glucose tolerance and type 2 diabetes in women was in double figures as opposed to the white women who had less than 2%. And that was the World Atlas of Diabetes at that time, where South Asia was leading the way and the epicenter. While the newer atlas and the projections in the next couple of years is focused more on Africa, and I would like to ask Helena at some point as to whether there were discussions with the African groups in terms of PCOS. And no doubt South Asia is coming probably about the third. We should be happy about it, but still for all, the expected numbers to rise is quite high. So in terms of possible ethnic variations in terms of insulin resistance of PCOS in South Asians in the 1990s, the one paper that came out from South London was that polycystic ovary, again the morphology, was seen more in British Asians, as much as 52% in a community study, as opposed to that reported in Caucasian women. And no doubt this group measured the insulin resistance by the gold standard test, and they reported that women of South Asian origin with polycystic ovary morphology but without diabetes had a similar degree of insulin resistance to the South Asian women with type 2 diabetes alone. So this stimulated me to look into ethnic variations, and the 4 studies that came out in that at that time in the late 90s there was one on Japanese women who were less obese, less hirsute, but had similar degrees of insulin resistance to the white women. Andrea Dunev showed that the Caribbean Hispanic women had greater degrees of insulin resistance when compared with white women, and that ethnicity and polycystic ovary syndrome had an additive effect. Rob Norman had studied in South Africa the Asian Indians, and their insulin response to a glucose load was significantly higher in the Indian women as opposed to the white women, while the previous study I referred to clearly showed that there was some link of insulin resistance with polycystic ovary morphology. And no doubt at that time there was much discussed on insulin resistance and diabetes, insulin resistance and coronary artery disease in South Asians, and my question was, what was it about PCOS? So we developed a hypothesis that there is an ethnic difference in the overt features of PCOS in women of South Asian descent, which is probably linked to the higher prevalence of insulin resistance in our populations. So we wanted to determine the phenotype, the degree of insulin resistance, as well as look at the testosterone and SHBG for research purposes in these two groups who came to clinic with well-characterized PCOS. And what did we find? We found that South Asian women living in the north of England who came with the well-characterized picture for infertility treatment, presented at an earlier age, had developed menstrual irregularity at a younger age, were more hirsute, had more acanthosis, had a higher prevalence of family members having diabetes, had significantly higher fasting insulin concentrations and measured insulin resistance, while their testosterones were similar but had significantly lower sex hormone binding globulin, which is in fact a surrogate marker of insulin resistance. So this was reported by us, which more or less overlap another study by George Alberti and others of British Asian children who at the age of between 5 and 7 were significantly more insulin resistant than white children of the same age and BMI. So when I came back to Sri Lanka after my sabbatical, I extended this study to Sri Lankan women who had much less consanguinity than the Mirpuri Pakistani women whom I studied in north of England. And yet what was striking was that in my study, there were quite a few women who had never left the shores of Sri Lanka, who had a lot of problems metabolically and had also probably been affected by the condition and led to marital problems. While there was impaired fasting glucose in much lesser number of British Asians. So when we looked at the three groups, it was clear that the Asian women were younger. Their age of onset of hirsutism was also significantly lower, while their BMI in the Sri Lankan group was in fact at a lower level than in these clinic attendees as opposed to the white women and the British Asian women, while the waist hip ratio, a marker of central obesity, was more or less similar in all three groups. Therefore, it was evident that the Sri Lankans, indigenous women, had central obesity greater for a given BMI, and this was the time when BMI was considered to be of the Western cutoffs in terms of obesity. And no doubt the Mirpuri Pakistani women were more hirsute, while acanthosis was more apparent in the Sri Lankan women. When we measured, having excluded the diabetics, the fasting blood glucose as well as the fasting insulins were highest in the Sri Lankans, while their insulin sensitivity was obviously the lowest. While the testosterone levels in these categories were similar, the sex hormone binding globulin was lower in the South Asian women, and it was a stepwise lowering which went in parallel with the insulin levels. So to summarize, the indigenous Sri Lankan women with anovular PCOS, when compared with the Pakistani British Asians, were significantly more centrally obese with a lower BMI, but had significantly less hirsutism but a greater prevalence of acanthosis, and were significantly more insulin resistance with higher free androgen index. So that shows that we ourselves have heterogeneity in our group of South Asians. And this was the first time that I met Rob at the RCOG meeting, where I was invited to talk about possible ethnic differences in the expression of PCOS. And there was clearly, obviously we have different determinants, racial determinants in skin manifestation, our cultural determinants which can affect our presentation, body configuration and so on. But the polygenic disorder that PCOS is needed careful, uniform phenotyping, but with some evidence, as Helena was referring to. So our question was whether there was any link between the different subphenotypes, whether it was androgenic, reproductive, metabolic, and so on, or the ovarian characteristics, and what were the epidemiological data. So our findings with a fairly detailed study was that of all the available evidence at that time was that there was a difference in expression, and of course it was with mainly case and comparative studies. It's very clear that the New Zealand-based Indians as well as the indigenous populations have more obesity, they had higher blood pressures as well as lower sex hormone binding globulins, while the Mexican Americans were more insulin resistant, had greater prevalence, and that was clearly ethnic based. What we had published by then was also evident that the South Asian women were younger, acanthosis was greater, and they were centrally obese, while the metabolic syndrome was also reported to be high in young women of Thai origin as well as from South India. So, therefore, it was interesting to find out there was so much of disagreement about the cutoff of the BMI and so on, but it was very clear that from the multi-ethnic group analysis that the Asians came out as shorter with a lower BMI, and BMI being higher than 30 was seen predominantly in the other groups other than the Asians. So to summarize these findings at this point, the Japanese were less hirsute with lower BMI. The ethnicity seemed to affect the Caribbean Hispanics much more than the other groups in America. The Asian Indians had a greater insulin response to glucose load, and there was a higher prevalence of polycystic ovary in the British Asians. The Mexican Americans had greater BMI and insulin resistance, while the New Zealand native populations also showed similar trends, and the South Asians had lower BMI but similar waist circumference and higher insulin resistance, while migration also did not appear to be the main cause. So when we looked at the US-based multi-ethnic groups data, which was fairly large, it clearly showed that there was wide variation, and that the Asians lumped together, the East Asians as well as the South Asians, were considered to have milder phenotype. But what was encouraging was that two groups of people independently said that a family history of type 2 diabetes in ethnic groups had a strong relationship to glucose intolerance of PCOS, and that acanthosis was commoner in these ethnic groups, which was similar to what we had found in our own data. So there comes the story of the cutoff as to whether we should use the 25 as the cutoff for BMI of obesity in Asians versus the 30 that is addressed as the overall international cutoff, and whether waist circumference needs to be looked at independent of BMI. So there was no question about it that there is variation. And what was interesting was, I'm sure you are familiar with this YY paradox of Chittaranjan Yagnik, who is so well known to you all, and Yudkin, John Yudkin, with whom I worked in London many moons ago, that they had the same BMI. I don't know whether they were age matched, but their body fat was clearly much higher in that of the Asian descent. So therefore, the BMI is not a good marker of the percentage of body fat which creates havoc and insulin resistance. And therefore, there was the support from many a group to take the cutoff of the BMI to be 25 rather than 30 for South Asians. And I think now, thankfully, it has come to be, but it took a long time for it to be accepted by all groups. And in fact, Rob arranged an Asia Pacific meeting in 2009, and he asked me whether we should need a new definition for Asians, and certainly there were many obstetricians from India who no doubt agree that the younger South Asians have more postprandial hypoglycemia and have greater cardiometabolic risk, and with ethnicity being the modulator, and also even the SHBG paralleling insulin resistance. But after all, it is the one and the same disease with different manifestations which we have to be conscious of. And I go back to the most important fact that our community screening showed there were significant metabolic problems in these young women whose average age was 24. And what was more important was that their psychological problems that affected their quality of life was not by obesity but by their degree of hirsutism. And that is something that we also need to take note of, because Asians generally feel that obesity is a sign of prosperity. And in fact, if somebody loses weight, they ask, why did you lose weight? So, and the other was that almost half had not sought assistance. So then we had this PCOS study group in RCOG. You can see a woman's disease, but majority men who are studying it. And the epidemiological variation clearly showed that in our Sri Lankan study, which gave probably a lower prevalence rate, but no doubt that they were younger and that there was a culture of silence. And the Chinese group's findings also showed that they were definitely younger than the other groups. Of course, these were the only two community-based studies. Others had a higher chance of selection bias. What about gestational diabetes? After all, women have to bear children, and when we studied women with gestational diabetes and without from our unit and recalled them postpartum 3 years later, because we knew they had become normoglycemic immediate postpartum, we found that the metabolic syndrome affected the great majority of them, those with GDM previously, and this was in parallel with the presence of PCOS. Of course, there has been numerous studies, and there is no question about it that gestational diabetes and PCOS in South Asians are definitely linked. Now, therefore, ladies and gentlemen, I would like to put it on record that indigenous Sri Lankan PCOS women, which can be easily translated to the South Indian and major parts of India, present at a younger age with early onset symptoms, greater degrees of central obesity, have more acanthosis, significantly more insulin resistant, as well as there is a link to gestational diabetes. So if we were to summarize hirsutism, obesity, there is a difference from the standard Caucasians, the white European groups, while the metabolic syndrome is also more frequent, while genotype, which I don't profess to be a genetics expert, but I did this for my thesis because at that time, insulin VNTR gene, a variable number of tandem repeats in the insulin gene, was thought to be linked to PCOS, but this was not replicated by our data. We in fact found the South Asians carried a lower prevalence of the abnormal allele. And this is the summary of one of my PhD candidates who's a scientist who's done quite a lot of work which is yet unpublished. But she found that there is ethnic variation, no doubt, whether it is the adrenal pathway or the gonadotrophin pathway, which has been reported from all parts of the world. But the FTO gene, which is linked to type 2 diabetes and obesity, has been found to be positive in Asians as much as it was replicated in our own data, which is yet to be published. And this FTO gene had a significant correlation with the BMI of our ladies at the cutoff of the Asian cutoff. So to finally put things together, we need to apply ethnic-specific BMI guidelines and not go by the 30 cutoff. Central obesity, which may be linked to epigenetics, needs to be taken note of. We need to take note of acanthosis, the fact that they start young. Hirsutism in the Far East Asians may be 3 or 5, as Helena said, while there is a link to type 2 diabetes and metabolic syndrome in family members, and therefore the primary caregivers are it's important to sensitize them to address the entire family. And the fact that there may be a link to the FTO gene mutation, and also to keep in mind of premature type 2 diabetes and cardiovascular risks, as well as non-alcoholic steatohepatitis, which seems to be a common feature and is in the press from a large data set from the UK, which there is shown to be a very major link between NASH and PCO.